My guest today is someone whose work is changing how people understand and live with connective tissue disorders. Alex is an osteopath, educator, and founder of Hypermobility HQ, a platform dedicated to empowering people with Ehlers-Danlos syndromes and hypermobility spectrum disorders to understand their bodies and manage them with confidence and clarity. Having lived experience with hypermobility herself, Alex brings a unique dual experience and perspective as both clinician and patient. Her approach is grounded in science, compassion, and the belief that the incurable does not mean untreatable. Through her clinical work, online education, workshops, and her upcoming book, Help, I'm Hypermobile, she's become a leading voice for evidence-based, patient-centered care. In this episode, we'll explore what it means to live with EDS and hypermobility, why so many people are left undiagnosed, and how chronic pain, instability, and fatigue affect every part of life. We'll also talk about her book, her own journey with hypermobility, and why she believes the key to better outcomes lie in collaboration, education, and body trust. Hi, Alex. Welcome to Owning Space. It's so nice to have you here.
Thank you so much for having me. I'm so excited to be here.
So, I wanted to start with asking you about connective tissue disorders. Mm-hmm. Could you start by explaining what Ehlers-Danlos syndrome means? Yeah. And what the difference between Ehlers-Danlos syndrome and hypermobility is?
Yeah, so just to talk about the Ehlers-Danlos syndromes as a whole, or EDS, as we can shorten them to, just to make it a bit easier to say. They're a group of connective tissue disorders. So there are different types of connective tissue disorders. There are some that are related to connective tissue hypermobility. There are things like, for example, Marfan syndrome, which is different from EDS. But when we come to EDS as a group, there are 14 types of EDS. Of the 14 types of EDS, all of them except for the hypermobility type or hypermobile Ehlers-Danlos syndrome have a known genetic marker. And I believe for all of them, it's a genetic marker that affects collagen specifically. Right. With hypermobile EDS, again, we don't know the exact gene or genes yet. There's research being done in that area, certainly, and there's some exciting progress being made, but we don't know it at the time of recording this. Mm-hmm. But we do know that something's happening with the connective tissue that makes it stretchier than it should be. So we have a hyperextensibility and increased stretchiness, and also more delicate and slower to heal as well. So it really is a disorder of connective tissue. In terms of, what was your second question? It was, how does EDS...
How do they differ? So how does EDS differ from hypermobility? And when I say that, even from my own experience, I'm on the spectrum for EDS. Mm-hmm. And for my whole life, I've just had very bendy hands, and people have said I'm double jointed. And then it kind of graduated to hypermobility, and now it's at EDS. So I'd like to understand the difference between hypermobility and EDS, and then secondly, from that, why is it so undiagnosed?
That's a great question.
I know.
Let's walk it way back. So let's start with hypermobility. So what is hypermobility? To appreciate hypermobility, we have to also think of flexibility, which are two terms which get used interchangeably when they really shouldn't. Mm-hmm. So hypermobility refers to an inherently increased range of motion in a joint due to connective tissue laxity. So if I take my thumb, and if your viewers are watching on the screen, they will see that I can move it in a range which is very much outside normal range of motion. And again, if you're watching that, do not do that all the time. You can hurt yourself doing that, but just for purposes, that's hypermobility. That's not because I've worked hard to stretch those muscles to allow that range of motion to happen. That's because I was born with a connective tissue disorder, which has resulted in connective tissues around my thumb joint, which allows that range of motion to happen. Comparing that to flexibility, flexibility is inherently use dependent. It's use it or lose it. So we can think of that athlete who has to work really hard in some instances to develop, for example, greater hamstring mobility so they can have they can hit the soccer or football better or whatever, right? That's an example of flexibility where it's a muscular control. And the key difference between hypermobility and flexibility, at least from my perspective as an osteopath and a clinician who deals with injuries, is that flexibility is characterized by control. Whereas hypermobility, because it's to do with laxity in the connective tissue in the joint, is uncontrolled. The joint is just going to that range, without really any thought given. You don't have to activate certain muscles or engage certain muscles to have, in my instance, my hand touch the front of my forearm. Moving on from that, so we can have different types of hypermobility. We can have localized hypermobility, which is where just one joint is hypermobile. I do see that occasionally. A really good example of that will be, and I'm sorry for all the hypermobility words, this is where it gets complicated, but I'll try and keep it simple. A good example of that can be acquired hypermobility that an athlete develops. So for example, a right-handed tennis player may start to develop hypermobility specifically in their right shoulder, their right glenohumeral joint, because they're moved back into that range of motion so much. Okay. Or a piano player may start to develop hypermobility in some of the joints in their hands. Again, that's an example of acquired hypermobility. So you can develop that through just repetitive movements, especially in childhood and early adulthood, as those joints are kind of continuing to develop. When it comes to congenital hypermobility, again, going back to that connective tissue that someone is born with, we can have, as I said, local hypermobility. So one joint's affected, regional. So maybe it's just that person's kind of arms or just their legs, or it's even axial. So their spine, their jaw and so on, and their pelvis. And we can also have general. So general hypermobility or generalized joint hypermobility is characterized by having hypermobile joints throughout the body. Right. Now, when it comes to assessment of this and agreeing on what it is, this is where it gets a bit complicated. Currently, we use the Baton scale for the most part. I've done an entire episode myself where I go into detail of all my issues with the Baton scale, and there are many, and there's research papers on this. It's not the ideal tool, but it's what we have and it's what clinicians use. So it is what is used right now. But we look at a selection of 9 joints and then we score the patient. And if they have more than 5, then they're generally considered to be to present with generalized joint hypermobility. Yeah. What we can say about the Baton scale is if you are scoring typically 5 or more, again, it can vary based on age and sex and what context it's being assessed in. So in the 2017 HEDS diagnostic criteria, we do add age and sex and some things which kind of can affect how that Baton scale is scored and how it's considered in the context of a patient. But in general, if you're getting 5 or more on the Baton scale, you have generalized joint hypermobility. Right. Now, that is not a connective tissue disorder. That's a description of a patient. That is a described characteristic of someone's anatomy. I can tell a patient that they present with generalized joint hypermobility. I cannot tell a patient that they have hypermobile EDS because I'm not a medical doctor. So that's outside my scope of clinical competence. But I am able to certainly assess and discuss and label patients with generalized joint hypermobility or tell them, hey, I think you actually might not be hypermobile. One last thing I'll say again, just to reiterate this, is that if you're not scoring 5 or more on the Baton scale, it does not mean that you do not present with generalized joint hypermobility. Right. The Baton scale is notoriously bad at missing people with generalized joint hypermobility because the majority of the points are in the upper limbs. So patients who have really hypermobile ankles or hips or a hypermobile spine or a jaw, they're being missed. So there really are a lot of issues with it, but it is the tool that is used, unfortunately.
And in regards to EDS, you mentioned that it would take, a clinician to kind of diagnose that, and that's out of your remit. Are there genetics tests, blood tests, kind of further lab tests that person would likely go for to be diagnosed with EDS?
Yes, so this comes down to questions about clinical management again. So according to the 2017 Hypermobile Ehlers-Danlos criteria, the diagnostic criteria that are currently used, the diagnosis can technically be made in the absence of genetic testing. Right. So it's classified as a clinical diagnosis, which means that it's based on medical history and assessment of various signs and symptoms. In terms of how we think about that, both as patients and healthcare providers. If you look up the form, which you can very easily find on Google, the third part of the form, it really requires a ruling out of other connective tissue disorders. Mm-hmm. And there are different levels of confidence that different clinicians will have in their capacity to rule out other causes of the symptoms of the patient in front of them without genetic testing. So some clinicians will want to do genetic testing for some patients where they could be seen by another geneticist or medical doctor who might say, hey, I feel confident diagnosing this without genetic testing.
Right.
That does introduce a degree of uncertainty to the diagnosis because what the genetic testing does is it does give a little bit more confidence, and I'll explain why I can only say a little in a second. But it's a difference that we see even culturally or geographically. So in America, most of the patients I see through my online clinic, they have had genetic testing. It's very rare I see a patient who's diagnosed with HEDS or HSD in America who has not had genetic testing. Mm-hmm. In the UK, it's the norm, and in the rest of Europe and elsewhere in the world, it is the norm for patients to be diagnosed often without genetic testing, unless if they have a reason why they've made that medical doctor concerned about other types of EDS or Marfan syndrome or other conditions. The reason that I say that genetic testing isn't as helpful as people sometimes think it is because it cannot rule in HEDS. So there's no current test for HEDS itself. What it can do is it can rule out other conditions. So there are known genetic markers for all the other types of EDS. We can test for those. We can test for other connective tissue disorders, and we can say this patient does not present with any of those. They meet the 2017 HEDS diagnostic criteria. Therefore, we're going to diagnose them with HEDS.
We can talk about this a little bit more in depth later, but when that diagnosis takes place and someone is diagnosed with EDS, what is the treatment plan?
That is the $1 million question. So again, there are a lot of problems, I'd say, all over the world with the strategy for managing a patient with HEDS. So unfortunately, there's no real clinician or medical doctor as of right now who seems to be the professional who is always in charge of that treatment strategy. So it's not like, for example, my mom had cancer and she had a medical doctor who was in charge of kind of helping to coordinate her cancer care. And that seems to be more established in cancer care in general. When it comes to HEDS, typically when the patient gets the diagnosis, a good geneticist should hopefully try to help refer them to some other healthcare providers, hopefully get them started on that journey. But then unfortunately, it usually falls to the patient to try to develop their treatment plan.
Right.
Now, this is difficult because you have the patient dealing with something that healthcare providers and medical doctors struggle to deal with, which is a multisystemic connective tissue condition that affects everything throughout the body for some people. So it's a huge, huge problem. I will say when patients see me, I like to start my appointments off with 2 questions. So I ask them, is today a good day, medium day, or bad day, just to get a sense of how things are. And then I ask them, if I was a fairy godmother within reason, what would you like to leave here with from today's appointment? And the number one request I get is a strategy. And again, that shouldn't really be falling to me. It does. And I tell the patient, look, I'm an osteopath, I'm a musculoskeletal expert, that is my scope of clinical competence. However, we're going to talk through your medical history. You're going to tell me probably about a lot of issues which are currently not managed or treated to the standard I want them to be managed and treated. And I'm going to have a talk with you about what I think we need to do and how we can do it, and direct you in conversations I want you to have with your medical doctor, GP, or if they have a good specialist consultant they're working with. I'm going to try and get the ball rolling, basically.
Yeah, and I guess from that level, it's kind of multidisciplinary. It could involve pain management. It could involve, supplements.
Yeah, I think the main thing for me is making sure my patients are safe and alive. So for me, that's number one when it comes to triage. And again, I'm not a medical doctor, but with my understanding, of my musculoskeletal expertise, and as an osteopath, I am required to be able to have an understanding of people's systemic health in a general sense. I had a patient earlier this week who's struggling to keep food down and who is losing body weight and stuff. And, she's been told it's anxiety, it's in her head, it's stress. And she was very grateful to me because I was the first person to say, this is not normal. This is not okay. I need you to go see this gastroenterologist because we need to find a way to make sure that your gut is functioning. So often I start with like life or limb, basically, in terms of triage. So trying to protect that person's literal existence. We then move down into two things. So when I think of it from a clinical strategy perspective, it's either what's causing the patient the most, harm right in the here and now, like what's making their life difficult, basically. Or it'll be what is the easiest thing that I can change the fastest? Are there any low-hanging fruits? And I say that because when you're working with patients who are really feeling lousy, it's helpful if we can get something moving in a positive direction to A, get them feeling better, and B, give them hope. Because if we can show, hey, this thing which you've struggled with, it actually is treatable. And look at how this simple, this treatment strategy that I've carried out through manual therapy or exercise or this like bit of lifestyle advice tip or whatever, if that's made a difference, maybe we can affect other things positively. So it gives people hope. And I don't like to give hope without good justification. I'm a very direct person. But if it's possible, I love to do that because it can really start to get that ball rolling. Because once you realize you can affect one thing positively, it sometimes gives you that bit of energy and I don't know, that force that you need to be able to continue to push to try and affect other things positively.
I love that. That was said so eloquently. Thank you so much. When people come into your clinic, what is the main set of symptoms that you hear?
So the most common thing, again, shockingly, is patients asking for a strategy, which goes to show how adrift everyone's kind of left, like they're just kind of thrown to the wind, and it's like, good luck. In terms of muscle and joint issues that people specifically come to see me for, I'd say the most common one is what people will call coat hanger syndrome online. So it's kind of that like upper back, shoulder, neck pain. The second most common one is low back and hip issues is the second most common affected area. It's very interesting when you think anatomically about those areas as well, because what they have in common is that they're where our limbs connect to our body. So we have a lot, this is heavy, my arm has weight and it's long. We need to control that mass on my body. How do we do that? We do that, of course, through the place where you can almost think of it where it hinges with my body. So those are the two most common areas I see. I do also see a lot of patients who are struggling with neck pain and headaches. Sometimes they're related, sometimes they're not. If they are, it's one of my favorite things to treat because the low point for me was having horrific headaches that had me in bed for days at a time. And I couldn't live any quality of life really. So I love working with those. But I take great pride in being a generalist. And I think it's important if you're working with HEDS patients as much as possible to be a good generalist, because very often the issue in the hand might be connected to an issue in the elbow, which might be connected to the neck. So it's having that highly specific knowledge and never ceasing to study, never stopping in, reading research papers, never, always trying to refine and refresh your anatomy and your physiology, but also being able to put it all together. Because everything's connected to everything. And if you have HEDS, you know this very deeply.
And I think it's taking a step back and looking at things holistically, which we'll go into in more depth. But you touched on your own experience. And the reason I didn't start with that in this episode is because I thought it was really important to go through like what is EDS and what is hypermobility. But can you tell the listeners your journey? What brought you to this point? Because I know there was chronic fatigue, there was different things going on in your life, and what that journey was for you.
Yeah, that's such a big question. I will try my best to answer it. And thank you for letting me talk about all the professional stuff first, as that's so important to me. But on a personal note, it's been hard, and it's something I struggle with because I look really well, and I am well in a lot of ways, but I haven't always been well. And a question I get commonly from patients, is like, are things always going to get worse? There was a video on TikTok, I've been meaning to reply to it for ages, but this person asked women in their 30s and 40s, like, what's it like? Like, are things going to get worse for me? And the truth in my experience, and what I'm so grateful for, is that because my symptoms are managed better now, my health is better. I feel better in my body at 33 than I did at 25, than I did at 22, than I did at 18, even than I did at like probably age 4. And that's where my journey kind of starts, going back to, you know, those early memories, age 3, you know, that, where I had growing pains. I had horrific, and they were not growing pains. Growing pains do not exist. It's nonsense. I can send you a systematic review debunking them. It is a myth. But I had serious chronic childhood pain, deep pain within my knees, almost in the center of my knees. And this breaks my heart, but one of my earliest memories with my mom is sobbing because my knees were in so much pain. I couldn't sleep. And she would joke about amputating them. Like, because, you know, kids have a really weird sense of humor.
Yeah.
I was like, kids always laugh at the weirdest things. But I thought that was hilarious. And the knees aching was so bad that I was scared to go to sleep. So I then struggled, you know, I was anxious for nighttime to come because my legs would ache so terribly. And they probably also ache during the day, but I could distract myself. I was a busy, you know, kind of curious child. I also had issues, and again, we were talking about this before we recorded, about kind of issues with research. So we're just starting to be able to really have a more clear idea of what qualifies as a co-occurring condition or comorbidity of HEDS and HSD, and what, you know, perhaps might not be necessarily. But I had issues with my airway as well. So my mom noticed I stopped breathing at night. She got me into my pediatrician.
Wow.
So I had early issues.
And this is all linked.
We know that people with HEDS sometimes have differences in airway anatomy. So we know, for example, that when they have surgery, we need to be careful with intubation because the size of the airway can be a bit different, and also the structural integrity, because that connective tissue might be a little bit floppy. But anyways, in my case, I was 4. I don't know what was really happening, but I had my tonsils and adenoids removed as emergency surgery within a couple of days because I wasn't breathing at night. So yeah, that, and when the Canadian healthcare system gets you in that fast, it means something's not right. So I had surgery at a very early age. I also woke up from that general anesthesia. So that's another thing that's common in people.
Jesus Christ,
yeah.
Alex.
I know.
Wow.
And this is my first time actually talking about this. I don't normally talk about this stuff, but I had these issues from an early age. They had to bring my mom back into the operating room. It was a whole stress, because you're not supposed to have, I think, people's, you know, it's a sterile environment. But the general anesthesia.
So how old were you at that
4.
point? Oh,
I wanted to bring the tonsils into show and tell, but they didn't give me them. I was really upset. The next week at show and tell, I'm like, they forgot to give me them, these surgeons. Anyway.
These damn surgeons.
Yeah. I then went on to have a lot of childhood fractures. So I fractured 5 bones in the span of 9 months, walking and slipping and falling on ice, and then jumping a few centimeters off the ground during gym class. So again, non-traumatic onsets of fractures. I fractured the growth plate in my ankle and the growth plate in my wrist. So my right arm and my left leg are not quite as long as they should be. It doesn't look, you know, it's millimeters we're talking about, but I mentioned that because it'll be important in a minute. And then I went on, of course, to have other issues. So I hope you're okay with me talking about this. I'm going to talk about it anyways because it's important. But when I was maybe 15 or 14, early teens, I had a period where I did not have a bowel movement for 3 weeks. And
wow.
Yeah, I know. So
Jesus.
I did not know at the time how serious that is, because if you get to 3-week line, you need to go to hospital. That's very much like a medical emergency. If a patient came to me and saw me, Alex, it's been 2 weeks or whatever, I'm going to tell them you need to go to hospital now, get out of my office. This is important.
I would have thought it would be 3 days and that's urgent, 3 weeks. So
we went to my GP and he was just very kind of relaxed about it. And, I remember I was walking home with my friend and I was asking her, when you're 14 or so, we didn't have Chat GPT. So I was just I'm like, how long have you gone without using the toilet? Just talking with her, trying to get a sense of what is normal or not. I didn't realize how bad that was, but that was certainly something which made my pre-existing gut issues worse. I was never referred to a gastroenterologist. I've never had any follow-up support. And it's those types of events are things that need to be taken seriously. And it goes to show again how these little, and I say little, it's not little, it's shocking. I've met 2 patients in my entire clinical career who have, come close to kind of that 3-week line. To be clear, mine did pass. I didn't happen to need like a surgery. They do different things to try and sort that out. I didn't need medical intervention, but it would have caused certainly trauma and probably relates to a lot of the ongoing gastrointestinal issues I have. Because people with HEDS, it's not just muscles and joints, it's everywhere. And as much as I've been able to sort out my muscle and joint issues, gut issues are a whole other level of complexity. Perhaps it's because it's not my specialty, but there's a lot of, it's just a lot all the time.
Yeah.
I then went on, my mom had terminal cancer. So she was diagnosed with breast cancer when I was 17. She died when I was 21. That was when the headaches started. So I remember I'd never had a headache in my life, came home after a piano lesson, and my head was I had horrific pain, and it was this distribution. So I'm using my 3 fingers and putting one above my brow, one across my cheek, one under my jaw. And that's a trigeminal nerve distribution. So again, it was never diagnosed. I didn't bother to go to the doctor at that point because I watched my mother be ignored about a lump in her breast for 1.5 years. And I was ignored about stuff like not using the toilet for 3 weeks. So I just assumed it was pointless to go to the doctor. So I didn't go. I dealt with it. I would just lie in bed in agony with a pillow on my face, waiting for it to end. I remember the first time the headache lasted more than a day because initially sleep would make it go away. But then it got to the point where I'd wake up with the same pain or worse pain, or not be able to sleep. And that was quite scary. So that was the low point for me. There's probably other stuff I've forgotten somewhere in there, but yeah, lots of different issues. I started to have polycystic ovarian syndrome as well.
Yeah.
I did go see my GP for that after I moved to the UK. I was 21, 22. She told me that I was too skinny to have PCOS, and weight appears precisely nowhere on the diagnostic criteria. So I then argued politely with her and explained the diagnostic criteria to her, and that I in fact did fulfill it based on my blood tests and other things. And she just told me that she's like, do you want me to put you back on birth control, which I couldn't go on because of family history of breast cancer and blood clotting stuff. So anyways, at that point, that was kind of like my journey in a very abridged version. One thing I should mention is I also had double jaw surgery. So I had my entire maxilla, so my kind of the area under your nose, if you imagine that, cut through, and my upper jaw moved up, and I had my lower jaw broken and moved forward. And the reason I mentioned this, I had that done when I was 16. It was because my jaw was so, I hate words like poorly formed or deformed, because like there's a lot of weight with those words, and I don't like to, I don't like to apply that to myself or my patients, but my jaw had not developed in an anatomically functional way. Okay. And my chin was so far back that I struggled to eat an apple. I couldn't eat a sandwich without all the filling coming out. So I was having issues eating food. I couldn't close my lips over my teeth without really trying to push them together. So if you're in -30 weather and you can't close your lips, your teeth get very cold. So I had that major surgery. And luckily the surgery went well. But 5 years after that, I had an infection occur in the bone. And I was studying poetry at the time. I was doing my first degree. I was an English major. My mom was going to be dead from cancer months later. We had a lot going on. And she took me, I had a fever and I was being sick and stuff. She took me to the dentist first because I had horrific pain, up high, kind of in my molar area. And he said, oh, it's just anxiety. It's Alex grinding her teeth. Yeah. Then though, I went home and my fever got worse and worse and worse. And I started having febrile convulsions, and I was sick like 30 plus times.
What age were you at this
20, point? Right before my mom died. So like 20, something like that, 2021. And then she took me to hospital finally. We go to hospital, and then they accused me of being a drug seeker and sent me home, which is unbelievable.
You're kidding me.
No, I'm dead serious. Yeah, I wasn't asking for drugs. I was asking for like an MRI or X-ray or something, but I didn't know. Again, I was there telling them, by the way, I couldn't walk. I was in a wheelchair. So like in my very, not super conscious and functioning state, I was trying to explain to them, I've had surgery. I have metal in my jaw. Could this be related? I didn't have any training at the time. I had no healthcare knowledge, no physiology or anatomy. So I didn't know anything, but I said, hey, I have this piece of metal in my jaw. Could the screw be infected? And without imaging me, they sent me home, and I was in bed, and I honestly shouldn't. That's the closest I've come to dying. I believe it would be diagnosed as a chronic osteomyelitis, although I was never actually formally diagnosed technically. My mom had the phone number of my surgeon who did the initial surgery when I was 16. And thank goodness she had that, because she called him and he told her to bring me in immediately. He operated, I don't remember anything of going there or the surgery, but he operated on me before his clinic day started, just removed the screw. So it was in, a very minor operation. It was twilight anesthesia. And he probably saved my life in doing so. But I didn't realize how serious all that was until years later.
I mean, that journey, firstly, I'm so sorry that you've been medically gaslit so much since such a young age. Your mum sounded incredible, and I'm so sorry that she's passed away and she's no longer in your life.
That's okay.
She sounds incredible in the sense of just going back to when you were younger, around 4 or 5 years old, and I could be generalizing here, but some parents might have just not really just been like, oh, the pain can't be that bad. It's hard to know a pain scale for a child sometimes. Yeah. But your mum took initiative and she sounds incredible. I want to also commend you on the fact that it sounds like you are more knowledgeable than so many doctors throughout your journey.
Yeah.
You, even when you said so, like the way you put it as well, you said that you argued politely with the lady who wouldn't give you a PCOS diagnosis. I've had similar situations, but I guess I've just agreed with it and just gone, oh, okay, yeah, it's in my head. That was kind of my journey in a sense. And now there's all this kind of backlash of me going, wait a second, you were wrong, I was right. Whereas it sounds like within your journey, you knew there was something wrong, you fought for it, but you researched that as well. So I really hope that you commend yourself for that. And a lot of your diagnoses sound like it's because of your own advocacy. And to have that advocacy from such a young age, that's incredible. So you're a superhero.
Thank you. It's I read somewhere online that, like, I don't know, the good healthcare providers, you almost become the person you'd wished you'd had. So when I have patients, like, I didn't even talk about all the eye infections. I had ear infections, urinary infections, thrush, like all these different things, weird skin rashes. Like, I wish someone had taken me seriously and given me just, even if they couldn't help me, just almost believed me. And my mom always did believe me. And for that, I'm grateful. Yeah. She didn't have the vocabulary and the knowledge to be able to argue as effectively as I'm able to. That's kind of how I've turned like some of the trauma I've been through into my profession and my life. Like I am at work and I have a bit of an unhealthy relationship maybe, but right now I'm enjoying my career and I need this time to throw myself into what I'm doing because it's the journey that I'm on and I wouldn't have it any other way, even though I do work a bit too much probably. But you become in a way like just the person you wish had been there for you. So every time I can talk with a patient and they're telling me about their horrific, urinary tract infections that their doctor's not taking seriously, or, something else, maybe they have a lump somewhere that someone's not taking seriously. For me, certainly, learning how to navigate healthcare systems, that's a key part of all this, is knowing how healthcare systems work. So learning kind of the machinery of NHS and private healthcare in the UK, and learning how to argue things in a way that makes sense to people who are in healthcare provider roles, who have certain types of training. That's, I'd say, one of the biggest ways I help to try and keep my patients safe.
And there shouldn't even be a question of arguing. We shouldn't have to. Just one example, I, and you started by saying with your journey, I look well. And there's this huge thing about invisible illnesses not being taken seriously. I actually recently posted about this on my Instagram about having a disability badge because I've slipped a disc in my back. Yeah. And going on the tube with this, please offer me a seat badge. Yeah. Has anyone looked up? Has anyone even offered me a seat, asked if I was okay? And it was actually quite sad. Yesterday I was on the tube and I just didn't wear it because I knew people would just give me dirty looks. Yeah. And that shouldn't even be a thing. That shouldn't even cross my mind when I'm in pain, chronic pain, which I know you've seen a lot of in your life. It shouldn't be something that we need to fight for. And I'm so sorry that your story from an advocacy point of view is so similar to not just women. I'm sure it's kind of gender neutral, but a lot of women that I've interviewed.
It happens more. I'd say anyone who's female presenting,
I think you can safely say
women,
that.
We can for sure.
Yeah.
I'll say it.
No, exactly. And I mean, the women I've interviewed, it's mainly been about that advocacy and not being listened to.
Yeah.
So Alex, we've spoken about the symptoms and different ways that you could be seen to be hypermobile or have EDS. What are the benefits of being diagnosed?
Yeah, so the benefits to diagnosis are huge. You know, I only got diagnosed in August of this year, and I was going into it knowing what I probably had. But I have to say I was shocked by how validating it felt. Like, and again, I'm quite jaded, but I went to the space and I was like, it's not going to be a big deal, whatever. But like, I'm happy I blocked off the rest of my afternoon because I was like almost like crying in a weird way, because it gives you a name, and there's something, even if you know that name in your head, there is something about making it official that's very validating. So I think 1 is validation. 2, diagnoses are meant to keep people safe. So people with HEDS or HSD should sometimes be treated differently in different contexts. There can be issues with serious things like general anesthesia, like surgical considerations. Different medications can work in different ways sometimes. So it's really, really critical from a safety perspective. As well, it can certainly help to hopefully have patients get health care. And I say certainly, it's not certain, but we want that diagnosis hopefully in the future, hopefully when the UK does start to have better guidelines, because right now there are no nice guidelines. So when a patient goes to their GP, it's not like this is your care pathway. You're kind of just at the whims of your GP and what they do or do not help you to access. But a diagnosis, the whole point is that it helps you to access healthcare. So those are just some of the benefits of a diagnosis. I have to say as well, like I'm happy that I have my diagnosis now, certainly. And one thing that prompted it for me is just the potential of perhaps being pregnant in future. And I don't know what I'm going to do with that. There's a lot of issues with pregnancy and HEDS, which we will talk about maybe another day or another time. But it's like, it is all complex. But for me, I knew that if I was doing something that, potentially could have some risks for my health, I didn't want to ever be pregnant and not able to advocate for myself to get the healthcare I need to keep myself and potentially, an unborn child safe. So that was kind of my personal reason, like in terms of why now, getting that diagnosis, as well as some of my symptoms progressing. So we touched on the gut issues a little bit. Again, if I was to just go see a gastroenterologist without that diagnosis, they wouldn't know what to do with me. Having the diagnosis theoretically should help, me to be able to access care from a gastroenterologist who hopefully will actually care about my HEDS and help me to manage my gastrointestinal health in a way that's appropriate for me.
And I wonder in a certain aspect, the acceptance of getting a diagnosis as well I don't know much about this, but the mind and body kind of connection of, I'm not going crazy, that chronic pain is there, it is a real thing, now I've got a diagnosis. I wonder if that acceptance, I'm not saying that it will make the person feel better, but that they know that it is a thing and it's not just this chronic pain that they have to, which is, I think it's really hard living with an undiagnosed condition is what I'm trying to say.
Yeah. It takes away that whole idea of that person just being extra or being sensitive. Exactly. Like they have, it's someone else, a highly educated, medical doctor has said, look, based on my professional expertise, this person has this. So it certainly takes that burden of authority almost off of the patient. Because even me, I felt embarrassed to talk to my family about it, sometimes embarrassed to maybe mention it to my friends. Again, I know we shouldn't, but I'm a person too. And I have feelings sometimes as well. And it really takes that like kind of the self-consciousness away. It certainly did for me, I have to say. And that's been, again, a huge benefit of having a diagnosis, is just being able to say, like, I have a diagnosed connective tissue disorder. I have diagnosed HEDS. One of the reasons, though, I do talk about on social media about people who are undiagnosed is because there are so many people who cannot access a diagnosis. So I just want to stress as well, like, a diagnosis is a privilege. There are people in countries where they will just never be able to get a diagnosis. There are people in countries where they could, but they don't have enough money. So it is a whole complex situation right now. And that's why you'll see me in a lot of my content use the word hypermobility, because what I want to say is HEDS, HSD, other hypermobility related connective tissue conditions, and undiagnosed symptomatic hypermobility, but that's very, very long. So I try and include people in this space who perhaps, like me, were not at a point previously where they could afford a diagnosis or just aren't able to get one for whatever reason.
So I want to talk about, there's a few things I want to talk about based on what you've said. One is when was it then you finally got diagnosed with hypermobility or HEDS?
Yeah, so it's actually, that's an interesting story in and of itself. So I was only diagnosed with hypermobile Ehlers-Danlos Syndrome this August, so August of 2025. I have known that I've had it for years and years and years. And although there are pros to getting a diagnosis, and as a healthcare provider, my position has to be that everyone who can get a diagnosis absolutely should, because a diagnosis is meant to help keep you safe and help you access treatment, although we'll get to how that doesn't actually happen sometimes in a second. There are also sometimes negative consequences of a diagnosis. I was actually advised by a medical doctor I saw years ago to potentially hold off on it just because of some of the potential negative consequences. And this is something I hear a lot from patients who end up also seeing me. In terms of potential negative consequences, I'm someone, sorry, I'm really doing all like trauma dumping on you, but I had a surgical procedure in my mid-20s that saved my vision. So I had blood vessels growing where they shouldn't be. So I was at risk of having very serious vision loss, basically. It was a long story short. I technically abused contact lenses. I wasn't as aware of how cautious you need to be with them. And because of, and again, this could be for a variety of reasons, but with glasses, I've always struggled to reconcile the peripheral vision with the vision in front of me. So I get a lot of nausea and actually fall over. Like when I've worn glasses, I'm just falling, tripping over stairs. I really struggle with balance issues in those situations. Anyways, I ended up having blood vessels grow in a part of my eyes where they shouldn't be. And in combination with my very thin corneas and my high myopia, so I was negative 7.5. I was very nearsighted.
Okay.
Yeah. Because of all that, I ended up having a procedure called an implantable Collamer lens put into my eye, where they take a knife, make an incision, and put a tube in. Easiest thing I've ever done. Wasn't painful. Seriously, I find it, the concept is really unsettling, but the actual process was very straightforward. But I was worried that if I had HEDS on my medical record, that it might prevent me from having future elective surgeries, which will save my quality of life, like that one did. Does that make sense to you?
But why would HEDS affect that?
Because of risk of harm. So your eyes are made of connective tissue. And my worry is that a surgeon wouldn't want to operate on me because of my HEDS. And I have had some patients. I had a patient that had some cyst issues where the surgeon wasn't as keen to operate on them because of their HEDS. And again, that's understandable. Yeah. But this patient was struggling to sit and struggling to function. So because we don't know as much about HEDS, and when I say HEDS, I do include HSD in there. I think there's a lot of issues with splitting them up at present. So if you hear me say HEDS, I mean HEDS and HSD. But when it comes to having that diagnosis, it might make people hesitate to do procedures that otherwise they would do on people without that diagnosis.
And essentially it's like on their hands, right?
Yeah.
But question, and this might be really stupid. So if they don't operate, you could have potentially lost your vision.
Yeah, it's in terms of the progression of that, I would have just in that specific instance, I would have had to have only worn glasses, but my quality of life was atrocious. I wasn't leaving the house. I was just sitting, not moving, because if I only looked forward, then I felt okay. The second I got up or moved, I had no quality of life. I couldn't exercise with thick glasses on. I couldn't move. So my quality of life was so abysmal that yes, although there is a risk, even in my, for any patient who has that procedure, sure, you could theoretically maybe go blind or have really serious issues from the surgery. My quality of life was so in the toilet that I didn't care at that point. So again, it comes down to good clinical decision making is the result of a risk and benefit assessment. But in terms of diagnosis, again, it can sometimes affect how healthcare providers treat you. So even in terms of maybe and surgical stuff, it's down to the surgeon, it's down to the procedure. I'm not a medical doctor. I'm not a surgeon. So I don't want people listening to this thinking oh, I can't have surgery. The best thing would be if they could have surgery by a surgeon who's able to take into account that they have HEDS.
He's a specialist in that area.
Yeah,
exactly.
One of the few instances I've seen this in a patient, it was a patient in his 50s who had hair transplant surgery, and he was talking to me about the surgery, and I said, hey, he's like, what should I tell the surgeon? And I was like, look, tell him you have HEDS. We'll see. Maybe he will care. The surgeon cared. And then he said, thank you for telling me. I'm going to change how I harvest the hair and implant it because your connective tissue is a bit different.
Wow.
I know. That made me so happy. So that's what we want, is we want surgeons who will, speak with, help you speak with the anesthesiologist to make sure anesthesia is maybe being managed differently, different medications sometimes, different joint supports during the surgery. Like, that's what should happen. It's just that it often doesn't happen, right? So a diagnosis is theoretically and should always be a good thing. It's just that sometimes patients get frustrated. So going back to negative consequences potentially, patients have told me they sometimes feel like they're treated differently by healthcare providers now because they have HEDS or HSD on their records, and people, there's a lot of stigma around it sometimes, even though, again, there should not be. And the healthcare provider may view that patient differently or have certain different beliefs that affect how they treat that patient. So that's a concern for some patients as well. Things like travel insurance and different things can cost more or affect people in different ways. One issue that's particularly problematic in the UK is because of how private health insurance works here. And again, every policy is different. Every company is different. Do your own research. I'm not an expert in this space, but HEDS is classified as a developmental condition. And for that reason, most private insurance policies will not cover treatment associated with it. So I have patients who have HEDS who, instead of getting the diagnosis, have been advised by their medical doctor to instead get the co-occurring conditions diagnosed or comorbidities diagnosed. I say co-occurring because I think it sounds better. But to get those co-occurring conditions diagnosed so they can then access treatment and have things covered by their health insurance, because when they get that HEDS diagnosis, their insurer might cease covering them.
Totally, yeah.
And this is in contrast, I want to say, to America, where, and again, I have to deal with patient healthcare in different countries. I try my best to get it right. Okay, so forgive me if anyone listens, I don't have it right. But in America, because of the Obamacare Act, developmental conditions or pre-occurring conditions cannot be excluded from insurance coverage. So I've had American patients who move to the UK and they're shocked because what they had covered in America is not covered. Yep.
It's awful. And as someone who lives with multiple chronic conditions, which in my later life I realized they're all connected, and in a weird sense, that's really overwhelming. But it's also, I'm like, oh, I get it now. It's that acceptance. It actually, in a way, I'm like, well, that all makes sense now. But my point to that is, living with a chronic condition and speaking to private health insurance, do they want to talk to you then? If you've got endometriosis, no, it's chronic. Okay, so my standard of living with EDS, EDS and endometriosis is going to be awful. Yeah. But because I might not die from this, you can't cover me. And similar to ADHD, right? Yeah.
It's a developmental condition as well. So it's all, the UK is very problematic in this respect. And again, I was talking with another patient earlier this week who said, like, can you, in my letter that you write, I write a letter for all my new patients that kind of summarizes my views on their situation. And she said, can you write a recommendation that my GP get me a gastroenterologist or neurologist or this and that? I'm like, look, I can write lots of things in a letter, but that's not going to happen. Like, we can try to connect people with healthcare providers, but to get that all covered by a private insurance policy or through the NHS, it's the reality as of right now is that's not going to happen. And unless, and again, this is not true for everyone. And in America, of course, situation is complex. There are people who have no access to healthcare, and that's an incredibly problematic position to be in. But for an American patient who either has access to enough money to fund their own care or a health insurance policy which covers care, I do see American patients who will have an immunologist that they see semi-regularly, a gastroenterologist. They have their own gynae. They're going for annual checkups. When I tried to get an annual checkup in the UK because I turned 30, I went to a private GP and I said, hey, can I have a checkup? I've turned 30. And he's like, what do you mean? And I'm like, can we just do some blood tests? I haven't had any blood tests ever. And he was like, and I, what do you want? Yeah. So I had to tell him, I had to make up some symptoms to tell him what he should test for to then get that done. And all I wanted was a standard blood panel. And the fact that we cannot access this in the UK, it really upsets me. And UK healthcare, I would say, is inherently anti-prevention.
I mean, completely. I mean, I remember once asking for a blood test myself, and my doctor on the eConsult thing messaged back saying, each vial costs us X amount, so we actually can't do that many bloods. And just one little bugbear as well, I had loads of bloods done the other month in hospital, NHS, had 15 vials done, but they didn't tell me and I had to fast before. And I was like, please, can I have a snack, a biscuit or something? Because I felt so lightheaded and they wanted me to stay in hospital for different things after. And they went, no, NHS can't fund it. Yeah. We used to serve biscuits, but we don't now. And I know that's a really silly example, but it just shows that the level of care, it makes me so angry. It makes my blood boil. Yeah. Firstly, your journey. And so many people I know have had similar journeys for different chronic health conditions. Yeah. And the care that we do need it doesn't have to be private, public or private, but it's with a chronic condition, I would argue we need more consistent care.
Yeah, it's much easier to prevent issues or to treat them early on than it is to let them progress and then have serious issues. So, for example, when I see patients with serious gut motility issues, so food is not moving at them in specific rates or so on, I'm always concerned about really serious consequences like gastroparesis, and you can have instances where people's gut basically stops working. It's rare, but it does happen, and people at HEDS are at greater risk of it. I cannot tell you how many times I've had to write to doctors to be like, please, like this patient is being sick after eating, or, they're going this many days without a bowel movement or weeks or whatever. Like they're having concerning symptoms. I'm really concerned. Can you do something? And the patient's just not able to make progress. And I do want to say, coming from a country in Canada, we kind of only have the NHS, if that makes sense. So we don't have the private healthcare they have here. And in Canada, it does vary by province as well. So it gets really confusing. But I understand that we have kind of limited resources and that the NHS is under stress. And I don't want people to think I'm throwing shade at the NHS. I'm not, okay? Yeah. But it has to be more cost effective when we look at it over a longer time period. Instead of looking through the 5-year election cycle, if we zoom out and look at like a 20-year time span, is it going to be more cost effective to do an annual checkup where we're doing blood work on people and trying to prevent issues rather than trying to fight fires once they've started? Probably. Yeah. So yeah, it's a difficult situation. I think that's one thing that has actually made me quite good here at supporting patients is in Canada, we only have public, or in Ontario, I should say, we really only have public health care. So the tragedy of what happened to my mom was that she went to her GP 6 times saying, I have a lump in my breast. I have a lump in my breast. I'm worried I have a lump in my breast. And because you can't just go get a second opinion easily, she really was stuck. And also culturally, it's something that really wasn't done, especially back in 2007 or 2010 or whatever. So in that instance as well, you get stuck sometimes, and it's hard to get unstuck. And it's sad that in the UK, to get unstuck, sometimes you have to go through the private system. Mm-hmm. It also doesn't necessarily mean that you will get unstuck, because in the private system, there's a lot of pitfalls. There are a lot of problematic, problematic clinics, I guess you could say, or healthcare providers, or ways that patients may spend money on things that aren't actually helpful for them. Mm-hmm. So it's a lot to navigate. And I really think that this whole issue boils down to the fact, this is just my personal view, my partner's a lawyer. And in law, when you're engaging with a complex system, the legal system, you have representation. You would never engage with the legal system without representation. Or if you do, you're probably not a very sensible person. In healthcare settings, you're dealing with an incredibly complex system built around a complex, your body, which is complex in and of itself, built around healthcare. And the problem there is we have the patient, who usually is not an expert and able to sufficiently represent themselves and advocate for themselves because they don't have the language and the education, speaking to the expert. And we have a big power imbalance, and they don't have someone there to say, hey, no, this is how this system works. This is how we need to do things. That doctor hasn't referred you for that test. That's not what they should be doing. That's not in accordance with the NICE guidelines or whatever. So I think ultimately, it's hard and it's all complex right now, but I think that's what a lot of this boils down to, is that people are not able to advocate for themselves. And that's why I try to make content, and like coming on here today to help people be better able to do that.
I love your content, by the way. When I found you and I fangirled you and I was like, please, can you be on my podcast? It's because there is a lack of information out there. And I think what you're posting on your socials is in a really digestible way, like that the questions that people need to know. Yeah. And I often think that, and sorry if I'm shouting on the podcast, I'm just very passionate about this, but is when you are in front of your GP or the rheumatologist or whoever the clinician is, I think there's often, speaking from my own kind of experience, a sense of overwhelm where you forget things.